Dr. R.K. We have Dr. R.K. Alwadi, who is Associate Director, Department of Pediatrics at BLK Hospital. He has a roaring private practice in central Delhi, and he will be moderating the session for today. We have three brilliant speakers for today's session. The first speaker is Dr. Rajni Farmania, who is Principal Consultant in Department of Pediatric Neurology at BLK Hospital. She's heading the department and running it successfully since around 10 years. And then we have Dr. Shambhavi Seth, who is consultant in developmental pediatrics, also at BLK Max Center for Child Health. And then we have Dr. Ranjana Mishra, who is consultant in clinical genetics. She has received her training from Gangaram Hospital and is now practicing with us in BLK. I would also like to extend a very warm welcome to our chairpersons for today. We have Dr. Shefali Gulati, who is a renowned figure in the field of pediatric neurology. She is the director and founder of DM Pediatric Neurology Program at AIMS since more than 30 years. She has an experience of more than 30 years and has done exceptional academic work in the field of pediatric neurology. We welcome you, ma'am. Then the second chairperson for today is Dr. Zafar Minai. He is the director of Umeed Child Care Center, Child Development Center located in Bhopal. He has FRCPCH to his credit and has done MSc Pediatric Neurodisability from Sheffield, UK. And he has dedicated 22 years in the field of pediatric developmental pediatrics. And we are very happy to have you here, Dr. Zafar. Looking forward to a very interesting discussion. This is to inform everyone that this meeting is recorded. I request all the delegates to please keep their microphones on mute. You can ask your questions in between in the chat box, and let's go ahead with the discussion. Dr. Alwadi, please.
Okay, good afternoon, everyone. So we will be starting our panel discussion on autism spectrum disorder. So autism spectrum disorder is a major neurobehavioral problem of global concern. 1 in 36 children in USA counts under this spectrum. And in India, the estimated prevalence is 1.12 per 100 children, which is roughly 1 in every 68 children suffering from autism. So mine will be a case-based approach, and we would be discussing the various aspects of this condition by the medium of case-based approach. So case 1, 18-month-old toddler was pointed out by the pediatrician to have delayed speech with no meaningful word and till now and not responding to name. Other milestones were appropriate. Child had a high screen time of 4 hours per day. He was suspected to have autistic features and was referred to a developmental pediatrician. How to guide the family? Dr. Shambhavi, please.
Thank you. Thank you, Dr. Alwadi. Thank you to Department of Pediatrics, BLK, and a warm welcome to all the chairpersons. So this is a very common presentation we encounter in our day-to-day practice. It's an 18-month-old who has a history of high screen time, which I think 90% of the kids nowadays have, starting in early infancy. And now the child is not speaking. There's no meaningful word. But I think more important thing here it is also is not responding to name. 18-month child would have developed a meaningful vocabulary of 5 to 10 words, but the child would definitely have had a stronger communication, rather a non-verbal communication. So basically, a child may not be speaking, but what a pediatrician needs to check is whether the non-verbal communication is there. And what do I mean by non-verbal communication here is how is the eye contact, which can be seen in the early months, how is the response to name, how is the to and fro communication, which starts at 6 months, how is the joint attention of the baby. Joint attention basically means when a caregiver is giving an object of interest, the child is looking at the object of interest, but simultaneously also acknowledges that the caregiver is giving. And response to name, which comes around 9 months. How is the child following simple instructions, like if the mother says waves bye bye or give a flying kiss? How is the child communicating the needs, whether the child is doing mature pointing or not? Is the child also communicating his interest, like, child likes a metro car going, train going, and child shows to the parent. So these are all the aspects of non-verbal communication which should be developed in a child who's 18 months of age. And that's what we need to see whether this is there or not. Once this is there, then the speech comes or a meaningful speech comes. That is how the development goes. And when we talk about verbal communication, we talk about how is the child understanding our commands, which is the receptive aspect, and how is the expression of the child, which is the expressive aspect. So here, like I enumerated, these are all the non-verbal communication parameters which we need to check, which is the eye contact, facial expression, joint attention, pointing, symbolic gestures, like if child wants water, the child can do this, for food they can do this, social gestures like bye-bye and all. So this is what essentially should be there by 18 months. And after that, we need to see how much is the meaningful speech. So to next slide, please. So these are the ages where we see these respective parameters. Next slide. Now, coming to the language delay per se, this child who is 18 months old has no meaningful speech. So, what are the red flags of language delay? If there is no babbling sound like ba 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 mama by 1 year of age, no single meaningful words by 18 months, this is the upper limit. So, a child by 1 year starts to speak single words, but by 18 months also the child is not having a single meaningful word, then definitely it is a delay. Word vocabulary of say less than 15 to 20 words by 2 years, not joining phrases like, simple phrases, papa, chalo, mummy, pani, by 2.5 years. So these are the simple ways where we can see whether the child has these language delay or not. And like I mentioned, first we have to assess for the nonverbal communication and then the speech. So this is how we are going to approach any child who has come with a delay in the speech. Now coming to the another important history, which is the history of screen time. And I think every pediatrician must have realized in the practice the screen time is the culprit, which is there for, as early as 1 year, 6 months of age. But what does the guideline say? So essentially, the guide recommendations by AAP and IAP also as well now, by in under 2 years of age, there has to be no screen time. By 2 to 5 years of age, maximum 1 hour of screen time, that too supervised, and after 5 years of age, maximum 2 hours of screen time. These are what the guidelines say, and that this message has to also go to the parents, especially those who are taking discharge from after delivery. If we can have this recommendation given in every discharge slip about the screen time. So, Dr. Alwadi, that's what I have to share about this case.
What we basically understood by this is that this child ultimately did not turn out to be autism. So do not miss a child with autistic features, have a high index of suspicion, and be careful. But don't be in a haste to use the word autism because it has a lot of implications. So keep your eyes and ears open, but be sure before you label a child with autism. So we will move to case 2, where a family comes with a diagnosis of autism spectrum disorder in a 3-year-old child. And they have been diagnosed and they want to now know the optimal management. Dr. Rajni, if you can join in, please enlighten us on this issue.
Good afternoon, everyone. And we are discussing on this slide So this child is already a known case of autism. And then when I approach towards this case, my goals are two things. Whether, next please enter. So whether I need to investigate, and the second thing is what treatment I need to give. Do I need to start any medicine? Because we all know autism has, typically we need to go through therapies, and that's the counseling. So next what I do is history and evaluation. So in history and evaluation, we want to understand, do we have some findings? We can just put on enter, and then we want to see in history that yes, is it autism or it is some autism mimics, where we point out towards these 5 common points. This is what I go to use in my OPD practice. That poor response to name by 9 months, poor eye contact, or the child doesn't enjoy peekaboo by the age of 1 year, the child doesn't follow a simple command that pick up this, and that's a red flag. And then not pointing and no joint attention by 18 months, no meaningful word by 18 months. So these are the common early markers where we go through and understand the child has autistic features, and then we'll check some physical markers like neurocutaneous markers. We want to see, look into some dysmorphism, and if the child has some kind of other neurological deficits in terms of contractures or hypotonia, then we try to understand whether this child has autism plus features. So when we see further, we want to understand it is isolated autism or autism plus atypical features. So what are these atypical features? When we have something high risk in pregnancy, like in antenatal and birth events, we have global developmental delay instead of speech delay. So child also has motor delay, then there might be something which is a kind of autism mimicker. The child has seizures, we have to look into whether we need to investigate. And then dysmorphism, neurocutaneous marker. Another thing is, suppose a child also has some cardiac defects. So there was a child with me who had coarctation of aorta, was operated, and now the child has autistic features. Then it again raises the antenna that does the child has some genetic basis to it? And then we further, in the continuum of this, we try to investigate the child. So as required, these are the multiple investigations which we can go through, starting from MRI brain and MRS is spectroscopy. In some cases, when we have severe autism, we have sleep issues, we might have seizures, we do go ahead with spectroscopy to rule out creatine deficiency. And then we have a set of blood investigations, and in some cases, genetic testing. So Dr. Ranjana can further spread light on this. We'll discuss about management in next slide. So do we have some indication for genetic testing in autism? Dr. Ranjana can share her experience on it.
Thank you, Dr. Rajni, for this question. So good afternoon all. As we all understand that genetic testing does form a very integral part of optimum management of a case of autism spectrum disorder. And we must remember one thing, that genetic testing is not to be done in isolation. It should always be accompanied by a pre-test and a post-test counseling session. We have various professional bodies laying down recommendations for genetic testing. And so what we see is that the American Academy of Pediatrics, the American College of Medical Geneticists and Medical Genetics and Genomics, and the Indian Academy of Pediatrics, they all recommend genetic testing, whereas the AAP and ACMG, they go for a universal, more broader genetic testing indicated in every child with autism spectrum disorder. At the same time, IAP is little selective in its approach, considering the resource limited setting in our country. So, as Dr. Rajni had enumerated the various scenarios where we can see there is autism, along with autism, there is some other comorbidity. We can call it autism plus. It is a complex case of autism, usually associated with intellectual disability, global developmental disorder, or structural anomalies, neuroregression, neurocutaneous markers, any dysmorphism. So these are the typical cases where you have better yield, much more yield of genetic testing. And So again, these professional bodies, they all emphasize genetic testing to be done in these particular situations.
So going ahead with autism management, there are three arms where we go through. One is educational interventions, which is the most common, and then we tell them that these are the therapies the child has to go through, medical management for certain condition, and then there is a complementary and alternate medicine with no strong evidence. There are multiple diets and other things which has no strong evidence in cases of autism for treatment. So next slide, please. So these are the three domains where we practice. One is challenging behaviors. If the child has any of these challenging behaviors, we can target our medicine for this thing. If the child has other neurological problems, like the child has seizures, has epilepsy, we will go through investigation and management related to that. And other thing is any other comorbidities in terms of gut problems, in terms of sleep problems. So gait and posture is if we need some medicine, suppose the child has some contractures and we are working up, we want to add some medicine for spasticity, we can add on. So depending upon the comorbidities, we add on the medicines and we reiterate the point that there is no specific cure in terms of medical management for autism, and we have to go through the process of training the child. So we can go ahead with the next one.
So the learning points from this, first you confirm your diagnosis and look for any additional features requiring individualized approach. And what was critical was Dr. Rajni showed 5-point, like not responding to name or poor eye contact or not following single step instructions and no meaningful word by 18 months. So these form some critical 5 points which every general pediatrician must screen the child for at 18 months. And if there's the slightest of doubt, then formal testing should be initiated. So we move to case 3, a 4-year-old child known case of autism spectrum disorder on regular occupational therapy and speech therapy for 6 months. Child shows no improvement on therapies. He is restless, has self-harm behavior, does not sit in the class for therapies on most days. Dr. Shambhavi, how do we approach this child?
Yeah, thank you, Dr. Alvadhi. I think one more enter, please press one more enter. So one of the most important management which everyone is doing for the autism is the multidisciplinary interventions. And I think this word has become like a double-edged sword where we know it is required. Multiple disciplines have to be there. But at the end of it, the family is benefiting less. So, first to start with, when we talk about autism, there are so many therapy allied professionals like occupational therapy, physical therapy, play therapy, behavior therapy, special educators, speech therapy, speech language pathologist, so forth and so on. I think there are more than 100 professionals which you will encounter. Now, if we write multidisciplinary therapies, there is no proper credential that every occupational therapy or every speech therapy would be adequately trained. So there is a big question mark about the skill set. Then the kind of activities which most of them would be giving, I'm not saying all, but it would be more of a pattern learning where a child is made to do a certain task every day, every day, every day, and that goes into a rote learning memory, and the child is able to do. Child has to match those shapes, child is able to do. But that's not what we want a child ultimately to function as, just to be a shape matcher. So the core issues of autism are seldom addressed. And that's what the problem with our case was, where the child was started on multidisciplinary interventions, took it for a significant number of months or years, but still the concerns. And what are the concerns? The social communication has not developed. Child is very dysregulated in a social environment, which is leading to a lot of behavior issues, which is often misunderstood as just hyperactivity or inattention. And lastly, the family is still clueless what they are supposed to do. Many of them create an alternate occupational therapy center at home with all the gym ball and the brushes, but that's not what they're expected to do. What is expected should be clearly defined. Next slide, please. So the approach to therapy in a child with autism has to be goals being clearly defined. So rather than from who does it, our approach has to change what they do. We are not saying that occupational therapy is not important, but there may be so much of overlap between what a ABA therapist would do, what a special educator would do. So rather than who does it, what they do. So the goals have to be properly defined, and the goal has to move from developing a non-verbal communication. What is non-verbal communication is based on a social emotional connect to the verbal aspect of the communication. Social emotional connect development is seldom addressed because everyone is working on speech and early education or some sensory issues. So social emotional aspect, which can be done through lot of play based activities like giving a working on eye contact, working on multiple instructions in a playful setting, working on pretend play, that needs to be done. Monitoring, again, if the goal has been set for next 3 months, the what are the gains, what are the how the pediatrician should be able to monitor what development gains the child has made. Addressal to comorbidities, because many times we would see the child who's not sleeping well, who has a comorbid ADHD having less gains in the therapy setting. So those need to be addressed. And above all these things which we are doing have to be documented so that if a child is moving from one doctor to the other or changing the cities, everything is very clearly legible and there that this all has happened. So next slide, please. So this is where we need to emphasize working on a model which is based on early diagnosis, where the family is involved. It is family mediated. It is cost effective to the family. It's not they are every month fishing out 50,000, 30,000 rupees for therapies. It is to be goal based, culturally sensitive, just not aping a model of ABA, which has been done in America, to be done in India. Also, it's going to yield the results. Now, no, that is not what we have to do. We have to do our culturally specific models and time to time monitoring. So, this is how we approach a child who has been diagnosed and needs multiple interventions when we talk about children with autism.
So the learning point would be to make realistic goals and continuously monitor and define and redefine our goals and keep family engaged and clearly communicating their role, how they are supposed to help us in the overall management. And it has to be an individualized approach. It cannot be some standard format. It has to be catered to the individual child. Right. So, case 4, we have a 4.5-year-old child, known case of autism spectrum disorder on speech therapy, not improving. He was advised to get an EEG test by the therapist. It came out to be abnormal. Now, child is in OPD for further understanding. How to go about this case, Dr. Rajni?
So, thank you for the question. And this is a very common scenario which we come across in the OPD, that they just come with an EEG report, and whether it was to be advised, not to be advised, that's needless. And then they come and want to answer what they want an answer on it. So what we do is whether to advise EEG on a child with autism or not. These are the 4 cases or case scenarios where we advise. If the child has had a seizure, we do it. If there is no seizure, but the child has intellectual disability, and in less than 5-year-old child, if the child has global developmental delay alone, and then we do a EEG. And if the child is primarily a case of GTD, but has some features of autism, not exactly in the spectrum, we do an EEG. And if the child has some abnormal movements, like a recent case I had, the child had some tics-like movement. And then to rule out any epileptic phenomena, we do an EEG. So next slide, please. And here we have some papers, which gives us a data of having epilepsy or epileptiform abnormalities in a child with autism. So this is a systematic review where it says that it's a large study with huge number of patients, and they've said that in around 12% cases, in a case of autism, we can have epilepsy, and prevalence of autism in people with epilepsy is around 9%. So vice versa, autism kids can have epilepsy, and in the children with epilepsy, it can have autism. So next slide, please. It's another study which says the sample size was 100 and it was run in India, 3 to 14 years, and there were three groups on that, and 23% had epilepsy and 8% had subclinical EEG abnormalities. What does it mean? That means child did not have any seizure, but EEG shows abnormality. So that's a known entity in a case of autism, where we get EEG abnormalities without having a clinical seizure. And in case of clinical seizures, we have generalized seizures more prevalent than a focal seizure, and subclinical abnormalities in which focal spike wave discharges are common. And children with female gender, abnormal neurological examination, adverse perinatal events had significant associations with epilepsy. So next slide. And there's another paper in which autism and ADHD, the cohort was both the patients and to understand whether epilepsy or REDs, that is interictal epileptiform discharges, how common it is. So this was between 6 to 12 years, and 130 students, 130 children were enrolled, and in which it shows high percentage. It is around 43% had epilepsy, and REDs, that means no seizures but epileptiform discharges, were in 42.3%. So in ADHD also, it was significant number, around 37.5% and 35%. So we can see that huge number of these kids have EEG abnormalities and epilepsy. It has nothing to do with the clinical presentation. So next slide, please. So to conclude that EEG should be done or not, I think we should have clear guidelines. If the child has regression, child has GDD, child has autism with seizures, abnormal movements, we are warranted to do an EEG. And when we get that report, we have to look at sensitively whether to treat or not. Epilepsy is common and it's a wide variation of range, 12 to 45%. IEDs are again common, epileptiform discharges, that is subclinical, whether to treat, not to treat. There is no consensus guidelines on that. And I would request Dr. Shefali to comment on it, whether what's her experience or what she has to say on EEG abnormalities and treating them. Shefali ma'am? If you're around, ma'am, please, can you comment on this case scenario?
I'm there, Rajni. Actually, there's a connectivity is poor because I was in that studio. You can ask me what I want to comment on because I couldn't hear completely
Ma'am,
before
this
that.
case is a case of autism and the child has EEG abnormalities, which is subclinical, but no seizures and no epilepsy. So what are the guidelines, or what should we do when we get these kind of EEG abnormalities in a child with autism?
We actually, we have to be very clear when we are getting EEG abnormality, EEG testing in these children, and we should be doing a sleep and awake both. I think these are something which is important. It's a miss. Many times, you just have. I understand. Like sleep and awake दोनों कराना मुश्किल हो जाता है कई बार, but it is very important to understand the SWI difference between sleep and awake in many of these situations with epilepsy. And then we have to take decisions which are based on different they are basically three-tier approach. Somebody may be having epilepsy and along with it having EEG abnormalities, उसमें तो clear है, right? उसमें आपने देना है, right? पर the दूसरा वाला है कि if you are having only I have isolated abnormalities in EEG, then you don't have to you can't give you don't need to give anti-seizure medications. If there are only occasional abnormalities either or like that, you don't have to give. And they are common to have some interictal discharges and all that. That is one thing, because there is a autism and epilepsy has a bidirectional link. So there are some same causes which are causing both autism and epilepsy, and sometimes autism may later on can have issues having epilepsies later. Pehle autism is diagnosed and then epilepsy comes, and many times some epilepsy patients later develops autism. Third situation would be in certain syndromic situations, and also in those cases when you have an SWI difference between sleep and awake. In those situations, then we'll have to see if it goes into AESIS kind of situation, then you like to give immunotherapy and you may like to give benzodiazepines initially, in those situations. But yes, every child with autism does not need an EG1, that we should stop refrain. And second thing is every child who is having an occasional discharge here and there, doesn't need to be started on anti-seizure medications. But yes, keeping in mind that if you have something associated syndromic, then you keep it, whether there is associated epilepsy with it, it will have to be individualized in
Yes.
these children.
So most of the cases which come to us in the private practice is speech delay not improving, get a EEG done, you get abnormal, and then they want some medicine for it. So that indication for EEG is also important, as ma'am said, and sleep and awake EEG that I had. That we should all be thinking that we need both the phases of sleep and awake to be covered to say that EEG is abnormal or not abnormal. So next slide, please. So we go ahead with this.
Thank you, Dr. Rajni. So we go ahead with the next case where a child has ASD. Now mother wants to have another pregnancy. She has the first child with the ASD. So how to do genetic counseling? Dr. Ranjana, I think this is your field, and so please enlighten us.
Thank you, Dr. Alwadi. So here, this family has come to a genetic clinic to understand the risk of recurrence. So now this will depend upon the underlying genetic etiology in the index child. To understand the genetic etiology, we have to do the genetic test, and it starts with the genetic evaluation. We start with the 3-generation family history, with a 3-generation family tree, pedigree analysis, a clinical evaluation to identify known syndromes, and with a special attention to the dysmorphic features, neurocutaneous markers, tone abnormalities, all those things. And if a specific syndromic diagnosis is made, like Rett syndrome, you go for the specific gene evaluation by whatever means it is indicated. Like for Rett syndrome, you'll do a MECP2 gene evaluation. And if you find appropriate clinical indications, then you go ahead and do the metabolic and mitochondrial testing as well. So metabolic testing, like you do a TMS and phenylketonuria, you go for MRI along with MRS for creatine peak in a creatine metabolism and transporter defect. Mitochondrial testing is indicated wherever a child has presented with atypical, not in the typical window of neuroregression, which is accompanied with every episode of illness, recurrent cyclical episodes of vomiting. So these are typical situations where you will do a mitochondrial genetic testing. Chromosomal microarray, whether a oligonucleotide array based or a SNP based array, along with the Fragile X testing in a male, these two tests, they form the first line of genetic testing in a case of autism spectrum disorder. And as our understanding of genetic etiology, genetic syndromes, and with the identification of newer genes is improving, we are gradually shifting to the second tier of test. In fact, ACMG and AAP, they are more proactive and in picking NGS-based testing like clinical whole exome, also whole genome sequencing as the first line of testing. And not to miss, there is a lot of emphasis on pre-test and post-test counseling, where you counsel the family about the utility, the yield of the genetic testing, and the limitations. It is very, very important what these tests are going to miss, because they think this is one test and it is like a DNA blueprint. It is going to give you answer for each and everything. Post-test counseling to help the families understand the results and help them make reproductive choices. Next slide, please. Next slide, please. No, we missed a slide in between. Okay, now coming to the risk of recurrence, this typically depends upon the underlying genetic etiology in the proband, whether it's a sporadic case where the risk of recurrence is less than 1%, or if it is an inherited genomic condition, whether it's an autosomal dominant inheritance or autosomal recessive or X-linked inheritance. Suppose your genetic testing has not identified any clear etiology, then in that case, you give an empirical risk. So for a couple with one child with the autism spectrum disorder of unknown cause, unidentified cause, the risk of recurrence in a subsequent child is in the range of 4 to 14%. And just like we see this pattern in multifactorial inheritance, where if the risk of recurrence is higher, if the affected child is of the less commonly affected gender. So if the affected child is female, where this is the less commonly affected gender, then the risk of recurrence is higher. It is to the tune of 7%. If the previous child is a male, then it is little less, about 4%. And if a couple has already has two or more than children, more than two children with the ASD of unknown etiology, the chance of a subsequent child with ASD can be as high as 32 to 36%. Not only this, we also counsel that even if the sibling of a child with ASD is not fitting into the typical parameter of ASD diagnosis, he or she may have some learning disability, some psychiatric or neurodevelopmental issue, and this can be in the range of up to 18 to 20%. So, as it was asked that what forms the first line of genetic testing in an isolated case of autism spectrum disorder, it's a pure autism spectrum disorder. There are no other comorbidities. So, a microarray along with Fragile X in all boys and in girls also, wherever indicated, wherever you find a X-linked inheritance pattern along with typical features, the girls also should be evaluated for Fragile X. These two tests, they form the first line of genetic testing in isolated ASD. And wherever microarray is not available, microarray is a test which is looking at the chromosomes in a zoomed way. So it will pick up small deletions and duplications, which are called copy number variations. So if not available, then a karyotype also can be done, though the yield of this test will be little less. It will be around 4%, whereas a microarray gives the diagnostic yield is up to 10%. Thank you.
Thank you, Dr. Ranjana. So broadly, isolated ASD, the approximate risk is about 10%, ranging from 4 to 14%. And if it is syndromic, then the risk is very variable. Genetic counseling is highly recommended to the family planning and other pregnancy. So that is where its major role is there. And key messages that we consider are important is that early pointers should not be missed during routine visits. We had that 5-point critical screening program. Then early intervention is the key for managing the case of autism spectrum disorder, identifying the target behavior for starting medications. EEG abnormalities without seizures are common and do not warrant medication always. It has to be individualized. And most importantly, I would say increasing human interaction and reducing gadget interaction is one of the main keystones in preventing autism spectrum disorder or minimizing its impact. So increasing human interaction. Now, I would request our chairpersons to please enlighten us on their experience and what they want to add.
Dr. Alwadi, may I? After this, I may have to log off because the show will
Sure,
start.
ma'am. You please.
Yeah, just wanted to say that very wonderfully presented and outlined. One thing to be kept in mind is that there are many conditions that are associated with autism. So, like you have Fragile X, you have NF, you have tuberous sclerosis, etc. And Down syndrome. So, when your genetic counseling is being done, then you have to also talk about the associated, syndrome thing. So, the syndromic the thing will be different. And yes, we do understand that we have seen the females are affected less. The ratio between male and female used to be 4.5:1 earlier, but now the ratio is coming down to 3.4:1. And because the child who is the child is having the female has autism, we found that we have the 7 to 8% is the recurrence risk in the next pregnancy versus 4% if you have only boys affected. And which she has shown between 25 to 36% different studies. So that is why they have to be counseled. And very important that the copy number variations are very important in these children. And that is why you should have important to do an RACGH first and not seriously directly go for an exome, because CNB becomes important and counseling will be very, very important. And in this situation, I think the heritability goes without saying, but yes, you do have environmental factors and epigenetics also, which will be playing important role. Thank you so much. Rest, I'll request Dr. Zafar to.
Thank you, Dr. Gulati. Thank you, Dr. Alwadi. First and foremost, congratulations to all the speakers. Wonderful presentation. Thank you to the management of for inviting me and giving me this opportunity. I would only add this, that we know why autism creates so much of confusion is because, as pediatricians, I always say we are trained to find the abnormals, whereas in autism it is the absence of the normal. So a very high level of suspicion needs to be aware to every pediatrician, and I think very well pointed out the risk factors which are there, which needs to be remembered, we should not be missed. Second, not to miss on the sensory issues, that is hearing and vision. Whenever we are suspecting a child with autism in less than 2 years or in less than 18 months. And more importantly, rather than labeling autism and the family running to Google Baba and then unfortunately going to all type of camps, I think more important in less than 2 years is to identify the risk factors, start addressing them, empowering the families. Everything should be child and family centered, and I think we have done justice if we address, because we know the maximum synaptogenesis is going to take place in this period. And as maximum studies quote, Wiggins et al. Is one of the biggest studies. If the diagnosis is made less than 30 months and proper multi-finding approach, empowering the families is provided, the chances of losing the diagnosis or change of diagnosis between 13 to 20%. So thank you very much. This was all what I could add because it was a complete package, I would say, a very concise but very complete holistic approach how to go about autism. Thank you so much. Thank you, Dr. Shafar.
Thank you, sir. Panelists, anything, Dr. Ritika, any queries we have? I am unable to view them so that I can direct to appropriate if we have. So I think we do not have yet any queries. Our panelist, finally, Dr. Rajni, anything that
Yeah, we have. So we don't have any specific queries in the chat box, but yes, we have some questions, and I have some question to me, and I can ask to Dr. Zafar. I want to ask that about the therapy centers. And there's one thing which we also counsel: please go to your therapist and discuss that. What is a therapy plan? And the biggest masquerader which I have seen in my practice is sensory features. Basically, when you see a lot of sensory issues in a child, we tend to start some medicine for the behavior and the mood because that comes as upfront for the family. The child has visuals and the child has auditory. We do say that go to the therapy center and your sensory issues will be targeted. But most of the times it is not wisely taken care of at the therapy centers. So I want to understand, do we have any specific therapies or what do we guide to those families? And Dr. Shambhavi can also comment on that.
No, first and foremost, I am a developmental pediatrician. So you can understand, definitely, your question is very relevant. I think Dr. Shambhavi put it in a very specific way that the quality matters a lot. Those who are providing the therapy. So what we, as I am the chairperson right now this year, unfortunately, Dr. Shambhavi is the chairperson of the neurodevelopmental chapter next year. It is our plan that we like to ensure that whichever family is taking any therapy, he or she should have a written program. Secondly, they should be the one who should be empowered. As far as sensory issues is concerned, the issue is definitely, if we say specific therapy, occupational therapists are the one who addresses the problem of sensory issues. Uh, Again, how many occupational therapists exactly deal with sensory dysregulation and then are able to provide the therapy? That's a big question mark. But yes, less than 18 months, like I always go with the four questions I always say for community identification. And the first is I ask the mother, like, are you satisfied with your child's communication and speech? Was there any regression? Because there we get the family disintegration, I would say, rather than a holistic disintegration. My second question is your child lost in his own world? This gives me the disintegration at the society level. My third question usually is this: does your child follow more than 3 to 4 instructions out of 10? Usually the answer is no. We immediately know that will lead to school dysregulation or disintegration. And the fourth is definitely the sensory issues. We know all of the five, amongst the five sensory organs, there can be, depending upon every individual child, the visual poor eye contact, there can be hyperacusis, there can be tiptoe walking, the holding can be improper. Rather than the pincer, it would be a typical grasp, which is again having issues, and the child may be having hyperactivity. Even a hyperactivity to an extent is because of the disintegration. So when we say disintegration, for me, it is these four different settings which are required. And when I plan my therapy, I am very specific that this disintegration should be addressed rather than just a therapy, speech therapy. For me, speech therapy means it needs to be where the first and foremost screen time should be zero, quality communication increases, and if at all communication is provided support, it should be empowering the families. Same comes for the special educator. It's just not a special education session. I need to understand whether the child who was understanding initially two to three command, rather I would say understanding, but following. He was understanding all the commands, but was only because वो अपने में मस्त था. He was lost into his own world. वो instructions follow नहीं कर रहा था. In that situation, we need to ensure that the best count the family can do is, like initially before the therapy, if the child is following not more than two to three single line commands, and the child is above 18 months, obviously we know single line commands comes around 18 months of age. So in that situation, it becomes more specific that the first change we see in the child is that the child would start following more than 3 to 4 line commands. Well, more than 5 to 6 commands which the child was not following. So this is how personally I would say when I plan my intervention for my kids, this is the approach which is followed at my place, because I call it inclusion as well as integration. And sensory integration is just for the self the child is having, because if the child is having sensory issues, he will have uncomfortable situations, he will have behavioral issues, and unfortunately, we start medicines for that. So this is how it needs to be addressed. The basic paradigm should shift from the medicines, and I always say medicines in autism should be a portal of therapy rather than a means of treatment. I'm not saying about comorbidities. I'm not saying about epilepsy. So with this caveat, but yes, purely for behavioral issues, until and unless the diagnosis is very delayed, already the reward system has been activated in the child, and now it's very rigid. It's not possible for the child above 7 years, 9 years, 10 years. Yes, then I personally feel behavioral medicines, the triple R's, they are definitely the first line which are needed, even if you want to provide any therapy. Thank you so much.
Thank you. So there is one query that if a child is having feeding issues till 18 months of age, especially consistency and texture of food and more social anxiety for adults and children, should this child be observed with suspicion? Dr. Shambhavi, if you would like to answer.
Yes.
Well,
Yeah.
Sir,
So,
I would like to, Dr.
yes,
Shambhavi,
please.
I would have to take leave because I
yes,
have to
yes, I
join
know you
another.
have another webinar. Sure.
Thank
Thank
you
you.
so much.
Thank
It
you.
was great
Thank you
learning
so much.
experience and sharing of knowledge. Thanks everybody. Thank you,
you.
Dr.
Thank
Shambhavi,
you.
for this opportunity. Thank
Thank you
you,
for joining.
the entire
Thank you.
group.
Thank you. Thank you.
So, yeah, so it's definitely a child who has a social anxiety, isolated, or with respect to the other development parameters. I think when we talk about assessment or evaluation, we have to look for the holistic development. What are the milestones? Just a sensitivity of texture and social anxiety, but the communication is good, language is good, is following instructions. Yeah, I mean, probably need to follow up and see. We don't start something immediately ki wo sab cheezein sensory is selective in food, so everything the child should eat. So, but it all depends on the other parameters of development. What the child is doing, is it failing on development on other parameters? Then definitely we need to look at that. But if it's just an isolated this, I mean, 18 months social anxiety is explainable, but gradually it should get better. At 18 months, a lot of children would not have everything to eat, but gradually they need to be followed up. I think the follow up here is more important if the other aspects of development are fine.
As a general pediatrician, I would just add that these things are so common at 18 months of age that to view this with suspicion would be slightly, you have to look at development only, because a lot of children will have, they are by personality or by nature being anxious, and food issues are almost universal at 18 months of age. Hardly find any 18-month-old eating very well, eating all kinds of food. So I believe we have to evaluate the child in detail, but per se this should not generate too much suspicion. Is it okay, Dr. Shambhavi?
Yes, like you mentioned, the other aspects of development are fine, and these are the isolated things, then definitely we can follow up in the subsequent visits.
Thank you. Thank you. Dr. Rajni, anything you want to add? Just one more query is there. I have CTC registration should be mandatory. I didn't get this one. Dr. Rajni?
I think so. The question is that should a child with autism be registered at certain
Dr. Vipin, please.
Yeah.
What exactly are you asking?
Yeah. Am I audible?
Yes, you're audible, sir.
We have a lot of child development centers, but we don't know which one is good, which one is bad, and there is no registration process as for clinics or hospitals or nursing homes or labs or hospitals. So my suggestion is that these child developmental centers, they should also be registered by somebody so that one can decide which one is good, which one is being run by less qualified people or non-qualified people.
Right.
Dr.
So I think
Shambhavi?
it's a very, very good suggestion and practical one. Only thing is, how do we go about it? Right now, what we have is individual professional registrations, like Dr. R with DMC or MCI, occupational therapies with IOTA, their organization, special educator speech people are with RCI. So I mean, till the time that that becomes a reality, which is the ideal thing, that the whole setup is registered, we should actually look for registrations of the professionals working there, whether they are qualified and registered or not, I feel.
Okay. Thank you so much. Thank you, ma'am.
So we have no further questions in the chat.
And it's 4 o'clock.
Yeah, it's 4 o'clock.
It's time to thank everyone. So thank you everyone for this excellent academic session. I must thank my panelists and the chairperson and the delegates for making it a nice meeting. Thank you. Thank you all.